Next up is feeding and eating disorders. There's 3 examples that we're going to apply to our work with youth. The first is binge eating, which is defined as recurring episodes of eating significantly more in a short period of time than other people would typically eat. And it's marked by episodes of feeling out of control with that eating. The disorder is associated with distress and occurs on average at least once a week over 3 months. Anorexia nervosa primarily affects adolescent girls and young women, and it's characterized by a distorted body image and then excessive dieting that leads to severe weight loss, a pathological fear of becoming fat, and at its most extreme, a number of other physical conditions that result from being chronically malnourished. So note that it's the distorted body image that leads to the excessive dieting or lack of intake of food, not you decide to diet, right? So this distortion in body image and not seeing oneself with an objective view is what starts this cycle. Bulimia nervosa is characterized by frequent episodes of binge eating, which we just talked about, followed by behaviors like self-induced vomiting to avoid weight gain or the consumption of laxatives to promote a purging. The criteria in the DSM-5 reduce the frequency of binge eating and compensatory behaviors, that would be the purging, that people with bulimia exhibit to once a week, whereas it used to be twice a week. So bulimia can be diagnosed with a once a week binging and purging cycle. OT can engage in CBT, DBT, motivational interviewing, which is our third treatment strategy that we'll be talking about, and also helping to instigate healthy habits and routines. Now, in some cases, the individual with the eating disorder, because they really are in physical danger and obviously in psychological distress, we would call in therapists, sometimes psychiatrists, nutritionists, and dietitians. So a range of other healthcare professionals would be on the team to help work with an individual with an eating disorder, as many, if not all, of the disorders we're covering today. But in particular, there is a significant danger of dying, right, from being chronically underweight. So that's the OT role. Gender dysphoria is up next, and it is defined as a marked incongruence between one's assigned gender, also sometimes known as natal gender, and one's experienced or expressed gender. So there's a mismatch. It can occur in kids, but it can also occur to our youth, so in adolescents or adults. We want to differentiate between a nonconformity to gender roles. That's the DSM-5's language. I would say that what that means potentially is that we have, girls that are super, super sporty and may at some points in time be called tomboys, or boys that don't conform to gender roles and, in fact, gender stereotypes, right, of being much more sedentary and interested in traditionally, and I use that in quotes, traditionally female pursuits. So, we want to be sure that it's not just the prejudice or the bias of the person that's doing the diagnosing that says, oh, this little girl or this little boy doesn't act like they should, right? And we're moving away from that, but it still absolutely exists. We also want to differentiate between a transvestic disorder. So in other words, the person has transvestitism, which is a cross-dressing. Also body dysmorphic disorder, where one feels that a part of their body or several parts of their body, there's something wrong with them. And psychotic disorder like schizophrenia. What we can do, we probably what we're going to do is refer this client on, but we can help them with developing healthy habits and routines that support them in their expressed gender identity. The rest of treatment has to do with psychological counseling and also medical treatment that may include hormone therapy or surgery to move the individual more into accordance with from their natal or birth gender to their expressed or self-identified gender. Next up are our disruptive, impulse control, and conduct disorders. When thinking about these disorders, we want to be really careful about racial biases and presumed cause of behavior that can lead to discrimination towards clients. So, one stereotype and also very tragically behavior on the part of uninformed clinicians is slating young Black boys as having impulse control or conduct disorders. And it's absolutely not true, and it's very, very damaging. And when we label someone with disruptive impulse control or conduct disorders, then they become stigmatized, and then that label follows them. So we want to be super careful about that. And there's many implications that then feed into the criminal justice system. Conduct disorder is defined as behavior that violates either the rights of others or major societal norms. You need 3 or more symptoms in the past 12 months, and they include aggression to people or animals, destruction of property, deceitfulness or theft, and a serious violation of the rules. So this is not, I made a mistake or I was being a dumb teenager, right? It's actually much more focused than that and intentional than that. It is the clinical precursor to antisocial behavior disorder. To be diagnosed, the person has to, the symptoms need to cause significant impairment in social, academic, or occupational functioning, and the disorder is typically diagnosed prior to adulthood. So in our kids or in our teens. Oppositional defiant disorder has at least 4 of the following for greater than 6 months. Angry or irritable mood, which can include losing your temper, being annoyed, angry, or resentful. Being argumentative or defiant. Often this has to do with arguing with authority or defying authority. The person may also deliberately annoy others or place blame on others for their actions. And there's a vindictiveness that is also present, and they're spiteful at least twice a month. Our application to OT, we have a role for sure. Sensory techniques to increase self-regulation. So if the person internally feels physiologically better, they may be better able to cope. Also working on coping skills, working on mindfulness and other stress reductions, and working on anger management. And there are anger management programs that OT does in fact implement and or help implement that can greatly help others. Next up is substance-related and addictive disorders. And we're getting to the end. I told you it was going to be a lot, and probably right around now, if not a couple diagnoses ago, it's probably feeling like a lot. So stick with me. We're in the home stretch, and I really thank you for your attention and learning about this really important topic. Okay, so this is a super broad overview because we could dig into substance related disorders for a long time. We could do an entire semester on it. So the top level here is that there's at least 10 different classes of drugs that include alcohol, tobacco, caffeine, cannabis, hallucinogens, and a range of them, inhalants like sniffing glue, opioids, a range of opioids, I said tobacco, and other substances. So each one has their own DSM diagnosis. It also includes, interestingly, gambling disorder. So gambling can be extremely damaging to an individual. Of course, they lose all their money, they lose their property. Does it affect youth? Potentially, as an entry, but the gambling part is more frequently seen with adults. Okay, so the action as we know it is that the brain reward system gets activated, and then that reward system, I ingest something or I gamble or engage in other activity. I have a cascade of chemicals go through my brain that says this feels really good, and then I seek more, right? So the vicious cycle is not that we ingest things that make us feel good, but that it becomes this cycle of seeking more and more and more. There are cognitive, behavioral, and physiological symptoms with substance disorders. It's frequently diagnosed in adolescents, especially with drugs and alcohol, street drugs and alcohol, sometimes prescription medication, but that varies. And there are many comorbidities. So it can occur with anxiety, depression, and a range of other disorders. So in effect, the individual is self-medicating to try to cope with some of the other mental health issues that they're facing. Substance disorders are difficult to treat. We don't know exactly what causes them and how to break that cycle, that brain craving cycle. There's also social pressures. There's media pressures. There's so many pressures that lead people to engage in substance use, which then could turn into substance abuse and dependence. So there's a range of psychological, cognitive behavioral, and behavioral therapies. There's motivational approaches. There's disease model approaches like AA and other 12-step programs, Alcoholics Anonymous, Narcotics Anonymous, etc. There are a range of pharmacological approaches that either interrupt the reward system in some way, either that they interrupt the reward system in some way, or by ingesting the drug, they negate the high, if you will, or they cause a negative response rather than a positive response, and that's present with some of the alcohol pharmacological treatments, like using antabuse, which makes you puke your guts out if you drink. Also, there's abstinence and relapse prevention approaches. So I've linked an article that goes through this in detail for youth. Again, I'm not giving it the time it deserves. We will see it in our work with youth, and it's a high-level overview for you. So we can dig in as much or as little as you like. Let's take a quick look at personality disorders. Again, we're not going to do them justice. We're just going to introduce you to them. In general, a personality disorder is described as an individual that has ways of thinking and feeling about oneself and others that significantly and adversely affect how they function in many aspects of life. So there's 3 clusters of personality disorders. In cluster A, there are things that cause a person to appear odd or eccentric. That includes paranoid, schizoid, and schizotypal personality disorders. In cluster B, it's things that appear dramatic, emotional, or erratic, and it's antisocial personality disorder, borderline personality disorder, histrionic personality disorder, and narcissistic personality disorder. And then cluster C is those disorders that cause one to appear anxious or fearful. So that includes avoidant personality disorder, dependent, and obsessive compulsive personality disorders. I don't know why I just didn't leave off the personality disorder of all of those. Sorry, you guys. All right. So we are just going to have a couple more slides about this. The person must express a pattern of thought and behavior that's significantly different from their culture in at least two areas: cognition, affectivity, interpersonal functioning, and impulse control. It must lead to significant functional impairment, and here's where it hooks up with our youth, needs to be a stable pattern that started in adolescence. Borderline personality disorder is just one of the many types of disorders, but want to bring it up because we may see it, and it is particularly vexing. So it's a pattern of instability in interpersonal relationships, self-image, and emotion. So think about it, really very linked with what our youth are going through in terms of their development. You can see that there's efforts to avoid real or imagined abandonment, unstable relationships, unstable self-image, impulsivity, suicidality, emotional instability, feeling empty, inappropriate intense anger, and transient stress-related paranoid thoughts. So it's a tough disorder, and we want to be on the lookout for it in our youth, as well as the others, but particularly because so many of these symptoms mimic what we might see as individuals go into puberty and adolescence and young adulthood. We want to be on the lookout. So check out the presenter notes for more, and let's just have a quick look at treatment. So we want to utilize trauma-informed care principles to be consistent, safe, and have clear boundaries. That's us and our client, not just our client. Be aware of symptoms so that we can expect them when they come up instead of being surprised by them. We also want to pay special attention to the suicidal ideation so we can plan accordingly. So OTs are mandated reporters. So if we suspect that somebody is going to commit suicide or has a solid plan for it and goes beyond just a mention of it, we need to report that. So we want to keep that in mind. We will also want to assist in creating a positive and stable self-image, and we can try DBT or DBT with family skills training. And then, there is a small evidence based around dialectical behavioral therapy combined with social skills training. So check out your textbook for that. And that's what we got for personality disorders. All right, so this is our last topic, and it is the topic of suicide. This chart shows you that in our teens and young adults, cause of death in the U.S. in 2018, courtesy of the Centers for Disease Control, you'll see those light blue boxes in the upper left. Suicide was the second leading cause for kids 10 to 14, youth 15 to 24, and also young adults 25 to 34. So a very frequent cause of death. We want to be aware of that because if we're working with youth, we're going to come across this issue. Each day in the U.S., there are an average of over 3,000 suicide attempts by young people in the U.S. in grades 9 to 12. 3,000. 4 out of 5 teens who attempt suicide have given clear warning signs. So we may be, in effect, the first line of knowledge and interrupting that suicidal ideation and attempt. Suicide risks include the following: mental health conditions, almost half; family history, attempts at suicide before, some of the ACEs like family violence or abuse, serious or chronic mental illness, gender, firearms in the home, life stressors, and intoxication or substance abuse. So we've talked about conditions that have a lot of these signs and symptoms, and now we're looking at the outcome in some cases is that the individual is moved to try to kill themselves or successfully end their life. Men are 4 times more likely to die by suicide, but that doesn't mean that they're 4 times more likely to attempt suicide. Warning signs. So changes in eating or sleeping habits, unexplained or unusually violent or rebellious behavior, a withdrawal, sexual promiscuity, truancy, so not going to school, or vandalism, personality change, agitation, restlessness, distress, or panic, talking or writing about suicide, even jokingly, giving away possessions, and doing worse in school. So you can see it's a laundry list, right? So how do you know it's that and not something else? Well, we always want to err on the side of caution and check it out, right? So if you're seeing it, you don't know what's up, check it out. All right, I skipped ahead from the last slide. So what to do? Take every reference seriously. That's my check it out. Ask the client directly if they want to kill themselves. Now, this can be difficult, but it's necessary. It's absolutely necessary. If they say yes, do they have a plan? Do they have means? And do they have a timeline for this? We want to call a crisis hotline whenever possible, especially if the client has mental health diagnosis, because there's dangers and trauma associated with calling the police. So we want to go mental health versus police whenever possible. We want to also report to our supervisors and not leave the person alone. So this can interrupt your day of work. It can interrupt what you were up to, what you had planned, but you want to stay with that person or keep them on the phone until help can arrive and take over for you. So things to do: call the child crisis hotline, inform your client and your supervisor, implement a safety plan if you have one that is in effect for your institution, and again, stay with the client or remain on the phone. An OT approach if the client is not in crisis, right? So if they're in crisis, we go to all the information I just shared with you. If they're not in crisis, we want to look at their history of attempts, develop a safety plan, engage in reality-based treatment. So some of the things that we looked at before and we'll go over when we discuss treatment. Facilitate their development of coping strategies and social and communication skills through meaningful occupations. Develop ways to organize their environment so that can decrease stress. It's not going to be the end all, but it can help. Develop ways to improve self-esteem and engage in family education and relapse and contingency management. All right. Here are some references for you if you have interest in any of these topics, and You've made it to the end. So that is our giant lecture on mental health conditions. Please jot down your questions, bring them to class, and I'll look forward to seeing you real soon. Goodbye, everyone. Thank you.